I'm Simon Harrison. I'm a now retired consultant neurologist and, as probably you know, the Getting It Right First Time clinical lead for urology. So what I want to do in the next half hour is just to give you what the sort of future holds for it. You may remember that it was a year ago that the national report was published, and that was built on visits to individual clinical trusts which had been carried out prior to that date. So just as a reminder as to what the Getting It Right First Time methodology looks like, essentially it's a data-based initiative. So what we did was to assemble as much information about an individual clinical service as we could do. Lots of use of HES data, but also other data sources. So the BAUS audits and registries came into it. We had litigation data, procurement data, anything that we could find that would be relevant to build up a picture about an individual department. And then armed with that information, I visited, along with the Girft team, all the trusts around the country, and we spent a happy 2 hours together discussing with senior urologists, with urology nurses, maybe coding staff, various other people, and crucially, senior trust managers, chief execs, medical directors, and so on, in order to find out something about what was going on in that department, what the challenges were, but also what was going well and what was being successful. And that information distilled down to produce the national report. And then, so we're on to the bottom bit now, and we're at the point now where we can begin to look back and see where we've got to, but also we can look forward to refreshing the data moving forward and a second round of trust visits, which I hope will start later this year. So what are the potential outcomes from this? And I think the first potential outcome is what people do after their trust visit. So did that have an impact? What did people take away from that? Has that been a trigger for quality improvement in that individual unit? The next thing that arrived was the national report. So again, that produced a focus on the quality improvement initiatives and potential. So what's been the reaction to that? And then beyond that, what's going on in the wider sphere? What other aspects have been covered as the year has gone by? So let's go through those. So let's look at what individual trusts have done to start with. And the way it works really is that Girft doesn't have any power to impose or make people do things. It's a lever and an opportunity for people to enact change within their own organization. And on the right-hand side is just a little Venn diagram which summarizes or makes the point that in order to engineer change, you've got to have a number of components. You've got to have an absence of external constraints which make change impossible. So if you've got difficulties with the volume of referrals coming in, with external facilities, with the way hospitals are arranged, then change may be difficult. Within the trust itself, you've got to have the possibility to enact change. You've got to have managerial support. You may need financial support and the cooperation of other clinical groups as well. But I think critically, there's also the urology team itself. Is it capable of delivering change, developing the agenda, showing the necessary leadership to push that through and make it happen? So those have to be in place. But what are the opportunities that are out there? Well, just some examples from the Girft process. I think one of the first ones is the way that on-call and emergency care is delivered. So within that, within Girft is the opportunity for people to look at delivering more on-call care directly by consultants. So moving the emergency patient up the agenda, if you like, and giving them perhaps the opportunity and exposure to senior urology care that they perhaps merit. There's also something in there about the difficulties of the lack of support that some consultants have when they don't have a middle tier of cover, And the recommendations are that the trust should be looking at how to support that urologist, how to prevent them being got out of bed unnecessarily, how to make their job possible and effective. The stone and retention pathways, I think, have received quite a bit of attention, particularly the stone pathway, and I think it's caught a bit of a wave. The NICE guidance has come out as well, and we've already heard quite a lot about that at this meeting. The retention pathway, I think, is also important. The idea that it's acceptable to put catheters in, send people home, and then leave them languishing in a sort of outside existence where nobody's really looking after their interests. And I noticed there was a paper, I think, from Belfast at this meeting, pointing out just what a lot of morbidity there is to catheterized patients sitting on a waiting list. And I hope that that is a group that is also receiving the attention that they deserve. There's a lever there if you are interested and want to push forward a day case agenda, day case bladder outflow surgery, day case bladder tumor resections, day case ureteroscopy. Then again, the Girft will report and will provide you with some leverage to take that agenda to your trust. And then finally, the possibility of improving the infrastructure in which you're operating and working. So I've already had one contact at this meeting to say that they're starting to progress plans to build a urological investigations unit, which I think every trust should offer. And someone also has come along saying that the last there's movement in terms of getting back to a urology ward as opposed to urology beds spread out all around the trust. So all these are things which I think Girft does provide the opportunity for teams to take away with them. And one of the initiatives that's hopefully coming online soon is a database or a searchable database of examples of good practice. So you don't need to invent the wheel yourself at every occasion. There are people out there who've already thought of innovative things, they've established good practice, and if we can take from their experience and short circuits to getting solutions, then that's ideal. And at the moment, we've got about 30 case studies which people have kindly sent in response to a request from us, and they're going to be circulated to the trusts, I hope, in the near future. And in the not too distant future, I think it's quite possible that there'll be a searchable online database within the Model Hospital portal, which will allow people to look for examples of good practice in a single site. And I think that would be a useful advance. So let's move on and just have a think about what's going on nationally outside of individual trusts. So I think, as I've said, I certainly had a big focus on emergency care and the way we looked after our acute patients. And it's, I think, a very, very important contribution has come from BAUS in developing the emergency care guidance there, or guiding principles. And what was encouraging about that is it aligned very closely with the messages that we were putting out in the national report: more consultant hands-on delivery of care and better facilities. And the other thing I think is really important in there is there's a commitment to doing further work to deal with those very stressful, difficult areas where the consultant who's on call isn't really equipped to deal with the emergency that's coming through. So sorting out a difficult problem in an obstetric theatre, or much less commonly, the emergency nephrectomy. So there has to be ways of dealing with those problems that means that every urologist can be on call confident that they can deal with that problem, even if it means that new protocols need to come in, for example, about putting drains in, packing and transferring patients to other centres. So one of the things that certainly I recognised as I went round was the extraordinary transformation in the urological workforce and the extent to which it's happened, where to a large extent specialist nursing has taken on the mantle of the delivery of a big volume of care, really at the expense of having middle grade, non-career grade doctors in post. But there was that concern that there's no workforce planning in association with this. There's very little delivery of training which is structured. and there's a very poor governance oversight of this work that's going on. And so BAUN, I was pleased to get an update this week to hear that they have progressed their work on in developing what they're calling an educational framework for specialist nurses. And that's going on as a global initiative, working with colleagues from the subcontinent and from Europe, for example. And that is all in line with the interim people plan, which was recently published by the NHS. And that includes this quote, not specifically about specialist nursing, but I think it covers it, encapsulates it, that the people plan within the NHS is looking to build up new ways of working, new roles within the NHS, and to, in doing that, put together competences, expertise, skills as packages so that people get credentialed and have a proper infrastructure supporting these developments. So I think that's very encouraging. I think cancer has its own work streams, obviously, and the issues that I really picked up on were two. One was the way that targets weren't working well, particularly for patients with muscle-invasive bladder cancer, and I was pleased to see that that is recognised at the highest level. NHS England medical director has given a commitment that that will be looked at and covered within a review of cancer targets, which is ongoing at the moment. So I hope that we will see movement on that soon. And then the other aspect there is the increasing, or the need to make sure that MDT working is efficient, effective, and particularly uses resources appropriately. And again, I think that is part of a recognised national agenda now. Amongst the not necessarily controversial, but the most developmental part of Girft was moving forward the concept of networking between departments. In other words, trying to embed and establish the idea that a urology service has to, in nearly every case, look at a bigger population than that served by a single trust or urology department. So that just thinking of urology on a trust-by-trust basis is actually proving inefficient in terms of use of resources. It's proving difficult in terms of or workforce planning, as some trusts find it very difficult or impossible to recruit to. And it is also not good in terms of patient pathways, of getting smooth, consistent pathways of care through the system. So in putting forward the concept of the urology area network, we've moved this onto the agenda. And one way of trying to build on that and get it really embedded was to do a national consultation suggesting potential configurations for networking across the country. So we sent that out to every chief executive, and the response was quite varied, as perhaps you might expect. So there were some people who simply didn't reply. There were some people who were enthusiastic about it and wanted to get on and progress it and could easily identify the trust that they expected to work together. And there were others who deferred to their local STP or ICS to look at the way that networking would develop. So I think what was achieved by that is to get people thinking about networking in a really practical and positive way. And if we sort of sat down with a spreadsheet, we could map out probably about 40 networks that would be likely to progress because their boundaries were well defined. There was agreement that they were trusts that could work together or urology partners that could work together. And perhaps another 15 where it's still completely unclear as to how networking may work. But there's no ability to impose anything. This is totally built on the idea that providing trusts will work out how they're going to provide urology services going forward. And that is being built on. I've been involved in, or at least as an observer, a minor contributor to the way that work has been going on in the Humber, Coast and Vale area. That's Hull, York and Scunthorpe, North Lincolnshire. So that there are areas where really this is beginning to get down to the project management stage. The other thing that you might be interested in, if this is something that you are looking at tackling, is guidance, if you like, on how to go about it, so that guidance has been circulated, and the most recent version of that guidance is going to be available to Trust very, very soon. And anyone who would like a copy of that can just email me and I'll send it to them. So, Girft is built on information and data, but we can all recognize immediately that if you're relying on the information and data which is available currently today in the NHS, then you're going to have immediate difficulties and weakness in the strategy. However, it's not a static field, so I think we're at the start of a data journey, and this is going to be transforming itself over the months ahead. What we've got at the moment is a data system which was built really for financial reasons, and it's now being shifted across to be used for quality improvement. So very soon, as urology is a pilot for the National Clinical Improvement Programme, so that very soon every consultant will have access to a dashboard of their own information and data. And BAUS has really taken the view, I think, that is now sufficiently robust that it can effectively replace the BAUS registries as the storage mechanism for information about procedures and work. On the commissioning side, Right Care is also producing a dashboard for commissioners, so CCGs can look at how their urology service is working. And so if you get questions on that coming through the system, then I'm afraid you partly have me to blame, because I did give some advice on that. Going forward, we need to be quite strategic, I think, in how we go about moving forward the information and data areas. And we had a very successful meeting recently with BAUS, with the NHS organisations, NSIP, Right Care, NHS Digital, National Prostate Cancer Audit team came along as well, just to look at how these issues should be addressed. And things like aligning coding, so that one procedure is coded in a particular way across the board, and therefore we can become more and more confident that we're capturing information that we want and that it's correct. The way that data is collected and stored, is it possible to get that properly aligned so that it becomes more widely available to those that can make use of that information, as well as being accurate? And then also moving forward to better data analysis, which I'll come on to shortly. And so that collaboration, even since that meeting, was only a couple of weeks ago, I heard yesterday that there have been further meetings going on. So I think that collaboration is very potentially extremely important. And there's the possibility that urology can position itself really as a pilot specialty for integrating with the NHS data collection and guiding that to make it as efficient and effective as possible, as useful as possible. So in terms of sort of the next level of analysis, because the Girft report, the analysis was pretty basic. It was really just comparing trusts with the raw data. And clearly we need to move beyond that. We're producing recommendations and ideas, but it's not really based on real rigorous analysis of data. But working with a statistician within the Girft process has been very interesting and illuminating. So for example, we suggested that we move towards more day case working, and we've done an analysis correcting for frailty, age, and deprivation and so on, to see whether differential day case rates for bladder tumour resection are based on those sorts of factors. And the answer is they're not. So the units with long lengths of stay on the left-hand side for their bladder tumour resections, as compared with the units with a lot of day case work on the right-hand side, they're seeing the same sorts of patients in terms of age and frailty. What we don't have there, though, is information about tumour stage, and that could only be got through audit. So we've moved along a bit of the way, but we would now need a clinical audit to really cement that. But nevertheless, I think it's important to see that patients with similar profiles on HES are getting the same outcomes on HES in terms of readmissions and so on, as whether they go through day surgery or inpatient pathways. So that gives a little bit of confidence in our recommendation. Another recommendation, which I think has for the last, 10 years been controversial is this one on numbers of complex operations which need to be carried out in order to deliver expected and good outcomes. Graph on the right is taken from the National Prostate Cancer Audit. This is patient-reported continence data following radical prostatectomy, and you can see there that there's a really very little hint that the bigger numbers as you go along the x-axis seem to produce any better rates of continence. So maybe there isn't that huge volume outcome effect there. But Girft and HES and the NHS data sources have the opportunity, I think, to try and get to the bottom of this issue so that we can make recommendations about numbers based on better evidence than we've had so far. And at the moment, I feel comfortable, having started that analysis process, that the recommendations in the Girft report are holding up, and we're not seeing big benefits from doing bigger volumes than we're currently pushing towards. So some of the other issues that we've picked up on through the year, the penile prosthesis discussion came to me late. I didn't get informed about it other than through BAUS. But when I was informed about it, the idea that we should only have a couple of centres doing penile prostheses in the country, I was able to contact the NHS England team, and just by having the label as the Girft clinical lead, they were happy to have a half-hour phone call and discussion, and we were able to point out that we needed consistent messages coming through all of the NHS systems, and that we'd given advice about indicative numbers or numbers for complex operations already in our report, and that they were proposing something which was way outside of that, and that was accepted. And the evidence or the reasoning behind that was also accepted. So I hope that that's levering to a more sensible regionalised model for advanced andrology services. Procurement's gone quiet. I haven't heard a lot about procurement since the national report came out, but there is work ongoing, so that I think urology, the focus will eventually come to urology and trying to look at increasing efficiency and effectiveness of procurement processes. For litigation, all trusts have been circulated now for their litigation profile, the cost of litigation for a clinical service per unit of activity, so that every trust chief exec medical director has a copy of that for all of the specialties. So if you're an outlier in that, you'll be getting a message or an invitation to come and have a chat about it and a review of litigation data at some stage in the near future. I think it's been interesting to see the way that the need for clinical input into the NHS is increasingly recognised. I think Girft has been quite successful, along with a lot of other areas, of course, in establishing that you can get hopefully fairly neutral, unbiased, non-trades union, if you like, advice for people within the NHS who are trying to make decisions. And really it's been very gratifying the extent to which that advice has been looked for and taken note of. So I think that's been useful. Get phone calls and emails from medical directors asking for comments on this and that. Now, some of that should probably come through the organisation and shouldn't just come through one person, and I think there's a way of dealing with that going forward. I was asked about no-deal Brexit planning under strict secrecy, but I will let slip that I advised that intraurethral alprostadil was probably not an item to stockpile ahead of a no-deal Brexit. I hope you all will back me on that. So just assessing the impact. How do we do that? Well, have we made any difference? Has this effort been worthwhile? So I think from the audit and anecdotal information which is around, I think change is out there. I think it is capturing a mood. I think it's interesting the way that BAUS is now talking, or the BAUS meeting is now talking a lot more about the way that care is delivered, or as much about that as to the precise details of the care that people are or should be offering. And I think that's good, and we've seen all these issues discussed and presented this week, which is in line with what I'd hoped to see. I think the next round of visits to Trust will again give further information and a sign as to which departments have found that Girft has been helpful, moved the agenda forward, and for whom it's really not had an impact at all. We've begun to look at analytical ways of seeing whether it's had an impact, and this is just some data that we've collected or looked at over the last few weeks. This is the use of stents for patients admitted acutely with a urinary tract stone. And the vertical line there is the, in the middle, 0, is the date of the Trust's visit by me. So that when the Girft lead visited the Trust. And if you do time series analysis, you can see that there is an upward trend in the use of stents for the months prior to, and years indeed, prior to the Girft visit. And then since the Girft visit, there has been a decline in the use of stents. It's interesting, and if we see that replicated across other parameters, then that'd be interesting. There hasn't, unfortunately, as yet been an increase in the use of acute ureteroscopy or lithotripsy on that same admission. But it's interesting that you could do these analyses and get some feedback. So what are the conclusions then? I think Girft is now sort of well established and embedded in the NHS. It seems there to stay for the foreseeable future, so that I think the second round of visits is inevitably going to happen. I think we're seeing increasingly that the idea that the profession is embedded in self-interest is being lifted, and that clinical input is absolutely essential to moving quality onwards. I think we have to recognise that Girft is really there to try and identify an agenda, and that it's not about delivering edicts and telling people what to do. That has to come from internally within urology as a whole. But Girft is a lever and an opportunity to make things happen. If you're having difficulties, then you have a Girft hub, a regional hub, which you can contact and ask for advice from. And I think they're actually working quite well. I wasn't quite sure how they would work, but they do seem to be quite influential. They have good contact with medical directors and other executives in trusts. We have to remember, though, that this is the real world. There are, I don't know how many Girft streams now, 25. If each produces 20 recommendations, you can do the sums yourself. You end up with massive numbers of recommendations, and then the CQC is producing stuff, NICE is producing stuff, and trusts are submerged by some of this. So the practicalities of working through all these agendas is difficult, and that's why there has to be a lot of drive from within the specialty. Financial challenges, workforce challenges in the NHS don't go away, and they really hinder some of this work going forward. So the first Girft cycle has been completed. I think there's now a need to embed what's gone well. We need to get the quality of data improving. I'm sure that's going to happen, and the sophistication of analysis of that data has to go forward. And there's a need to increase the collaboration between different quality improvement processes. So the next steps then, well, I'm sad on one hand and very pleased on the other that I'm stepping down as the clinical lead shortly. An advert will be going out hopefully within the next month, I would think, also through BAUS to look for interest in my successor or successors. The trust data pack is going to be refreshed and hopefully expanded with some new information, maybe the GMC training survey data, for example. The second round of visits are going to then happen. And after that, I'm not quite sure about the national report. We've had one national report, and maybe something different might follow, maybe a more aligned strategy for quality improvement across urology, which is multi-organisational, both from NHS organisations, from BAUS, and from Girft itself. And that would be an interesting development for the next clinical lead. So that's the update. My time is up. Thank you very much. So my time actually is up, so I think it's lunchtime. If anyone wants to collar me for any questions, then I'll just hover at the front here. So thanks very much.